Okay, I think we'll get started and people continue to filter in as we do. As I said, I'm Tom Ketchkamethy. I'm Executive Director of the American Academy of Political and Social Science in beautiful, but right now, rainy and really dreary Philadelphia. And thank you all for joining us today for this webinar on the community consequences of the opioid epidemic. A couple of pieces of housekeeping first. First, we're recording this event. You should have heard that when you came on. And we're going to share this recording with all of you in the coming days. We'll also post it on our website. Second, that this session today is based on a volume of research that is inclusive of the presentations you hear today, but much broader than that with many more contributions. That volume of the Annals of the American Academy is now free and open for the next 60 days before it goes back behind SAGE's paywall. Thank you very much, SAGE Publications, for doing that. And I think we're going to put a link to that volume in the chat. Third, we're live tweeting today's session using the hashtag Academy Meets. So if you are Twitter inclined and you want to join the conversation on Twitter, please do. And last, there's going to be a brief Q&A at the end of the session. We're going to try our level best to at least carve out time for a couple of questions from you all. So please use the Q&A box at the bottom of your screen if you have questions for our panel or just general questions. And if you're having technical difficulties, just use your raise hand function and somebody on our team is going to reach out to you and try to resolve that. So on to a very brief introduction of today's panel, the panelists. Shannon, I will be back to you. I'll explain in a second with a general overview of the volume. Today's panel includes Shannon Monnat, a sociologist from Syracuse University, who's also chair of the Public Health Promotion and Population Health, Public Health and Population Health at the Lerner Center there. She wrote a piece in this volume about demographic variation in federal drug overdoses, and she's going to be presenting on that topic today. Lindsay Bullinger is a professor of public policy at Georgia Tech, where she's also affiliated with the Children's Pediatric Research Alliance there. She wrote a fascinating piece for us on the effects of opioid treatment programs on child well-being. So you're going to hear a bit from her on that later today. Jessica Pack is a professor of social work at the University of Wisconsin-Madison, whose work centers on the ways in which inequalities in very early childhood, even prenatal inequalities, can be the drivers of later life and adult outcomes. Her piece in this volume is about the effects of opioid use during pregnancy on infant health and well-being. So you'll hear from her on that. Jessica Drescher is a doctoral student in education policy at Stanford University, where she works with Sean Reardon and Keith Humphreys. Her presentation for us today is going to explain what the really remarkable Stanford Education Data Archive can tell us about the effect of the opioid epidemic on student learning rates across the country. And we also have Colleen Heflin, who's associate dean and a professor of public administration at the Maxwell School at Syracuse University. Sadly, though, Colleen is only with us in the chat. She's one of the co-editors of this volume with her colleague Raj Darolia from the University of Kentucky. And she was going to give you an overview of this entire volume in her opening commentary today, but she's been stricken with allergies that have reduced her voice to the barest possible whisper. And it's really not functional in this setting. So we're really sorry first for Colleen that she can't represent her own work, but being the good and organized professor that she was, she wrote out her comments beautifully, and I will be channeling Colleen for you in just a couple of seconds and reading off what she would have said at the top. And then, of course, we're quite thrilled to have Jason DeParle from the New York Times moderate the conversation today. Jason's decades-long reporting and book writing on poverty has won him national acclaim, as has his more recent writing on the relationship of immigration and migration flows to worldwide to poverty. When I reached out to Jason about the possibility of him moderating today's panel, his response was immediate and incredibly gracious. Quote, I know virtually nothing about this, Tom, but I do have an interest, and if a journeyman will do, I'm happy to read the papers and give it a go. So Jason, thank you very much for doing that and for doing this. So with that, I'll turn it over to you.
Thanks, Tom. Yes, I'm here in my journeyman capacity. And the first thing that came to mind when you mentioned the panel was a reporting trip I took last year to Huntington, West Virginia, where I'd gone to talk to families, not about opioids, but about SNAP and the EITC. But the impact of the epidemic was everywhere. It was impossible to miss, and I think also impossible to fully grasp. The first person I went to see had a bumper sticker on her car that said, I carry naloxone. The second had told me she dropped out of high school when because her sister had gotten addicted and she had to start raising her niece at 15. You know, there were so many buildings in Huntington that had been converted into recovery centers. I actually started taking pictures as I drove by out the window. And I saw the first yard signs I had ever seen that said foster parents needed. So in the language of today's seminar, it was clear that the epidemic had profound community consequences. I'm like the rest of you here with us today, I'm eager to hear more about those and what they've been, not only in Appalachia, but nationwide. To get us started, Tom, I think you're going to take the place of Colleen.
I am. So I'm reading now Colleen's prepared remarks, which were basically, why do we do this volume in the first place? Why do we do this project? And what are some of the top line findings? So here I am channeling Colleen. Before the COVID-19 pandemic started to dominate the collective consciousness, the opioid crisis in the United States was widely recognized as one of the most important public health emergencies of our time. In 2019, almost 50,000 people died from an opioid overdose in the United States, almost sixfold an increase from 2000. In 2020, the number of opioid-related deaths surged almost 40% from the prior year to about 69,000, and then spiked a further 20% to almost 81,000 deaths in 2021. Some of the conditions brought about by COVID-19, including isolation and overburdened health systems, likely contributed to the rise of opioid overdoses. Both the COVID-19 and opioid crises put pressures on the same public health, social service, and education systems. A great deal of research focuses on those people who have been most directly impacted by the opioid crisis, individuals with opioid and substance use disorders themselves. Academics and practitioners have focused on them to answer important questions like, what's the effect of opioid use on the body and brain? What's the efficacy of treatment pathways for opioid use disorder? And how can we best save lives? My colleague Raj Darolia and I developed this volume of research with the ANNALS to stimulate our understanding of the consequences of the opioid epidemic in a variety of societal and community domains, including child welfare, living arrangements, education, food insecurity, housing, and public budgets. These are topics that often lay outside the formal conversation that's focused on the direct effects of opioid use. The motivation for this volume is to focus on the less proximate consequences of the opioid epidemic in communities. Our aim is to both provide research that helps us understand the effects of the epidemic on families and communities, and to increase research in this area through a greater understanding of the measurement and methodological challenges that are inherent in asking these sorts of questions, as well as the potential policy implications of providing evidence. Recent high-profile litigation and settlements among states and local governments with drug companies have highlighted some of the local costs of the opioid epidemic, with huge dollar amounts discussed in some of those cases. While these lawsuits have been notable for the size of their settlements, the total societal cost of the opioid epidemic is likely much, much higher than contemporary litigation contemplates, because of the less direct harms that are visited on families, households, social structures, and communities by the crisis, and that have not been factored into the equation. Localized and more specific estimates are important because the negative effects of the opioid epidemic have not been equally distributed across gender, age, and ethnicity, race. You'll hear more from Shannon about this in a second, with changing patterns across geography and time. In this volume, we aim to improve our understanding of the consequences of the opioid epidemic in a variety of societal and community domains where there is little existing research. We charged 31 researchers with diverse disciplinary perspectives to consider the collateral consequences of the opioid epidemic in the United States using a variety of data sets, measures, units of analysis, and analytic techniques, from descriptive work to more causal work that provide us a much more nuanced understanding of the broader facts of the crisis across different periods of the epidemic. So let me highlight a few of the top-level findings from the volume. First, individuals involved with opioid addiction face more than a serious health issue. There's an urgent need for holistic policies that treat the whole person. For example, individuals with opioid use disorder may have critical food and housing needs that make it harder for treatment programs to be successful. While their addiction-related health needs require more significant focus, opioid-related policies should address their individual needs holistically. Second, individuals involved with opioid use disorder are embedded in families and communities and serve societal roles as parents, caregivers, and employees. The disruption caused by opioid use can cascade out of the family system across multiple generations, impacting the effectiveness of our education system, straining social services like child welfare, increasing food insecurity, and reducing productivity, ultimately creating fiscal burdens beyond the direct effects documented to date at the local and state level. This suggests that solutions need also to be far-reaching and encompassing. And finally, given that the demographics of the opioid addiction crisis are shifting to look more like other measures of inequality, policy approaches that account for the social determinants of health are increasingly relevant. And given that opioid addiction is morphing once again into a fentanyl crisis, the need to focus U.S. societal structures, there is a need to focus U.S. societal structures in ways that address loneliness and despair, and these are more critical now than ever. So those are Shannon's, not Shannon, I'm looking at Shannon's face. Those are Colleen's opening remarks. Back to you, Jason.
Tom, as Colleen's surrogate, would you mind briefly summarizing what she found on food insecurity?
Sorry, I was on mute. Happy to do that. The connection between food insecurity and the opioid epidemic. My own research, remember I'm Colleen, my own research often focuses on food insecurity and other measures of economic well-being. In this volume, she did joint work here with, I think it's Shiwan Sun. She examines the link between food insecurity and opioid-related mortality by focusing on areas of high prior rates of OxyContin misuse. OxyContin is a highly potent extended release opioid and was among the most commonly abused narcotics through the 2000s. However, in 2010, OxyContin was reformulated to make it more difficult to inhale or inject, and as a consequence, many people with opioid use disorders switched to using street drugs. The reformulation has been shown to have had many unanticipated consequences, and Colleen and colleagues find that states with higher initial OxyContin misuse rates have had an increase in food insecurity after OxyContin reformulation by about 2 percentage points, by year, 6 to 7 years after reformulation. That's 2 percentage points by year, 2 percentage points by year 6 to 7 after the reformulation. Their interpretation is that drug reformulation has shifted the demographic profile of opioid use disorders toward the groups that are already more likely to be food insecure. This is a contrast to demographic risk profiles of opioid users earlier in the epidemic, when a prescription was often required for drug access and may have worked to limit the extent of food insecurity at the population level. So the public policy implication of this is the public policy needs to get much more creative to consider not only the direct addiction-related health needs of the opioid user, but to look at the whole person and consider their food, housing, transportation, and other ancillary needs.
And that's a good transition to Shannon, who's going to tell us more about demographics, the demographics of the epidemic. Shannon?
Right. I'm basically here to just give you some background context on the overarching problem of the overdose crisis more generally before the others step in and talk about some of the collateral consequences. So you've probably heard the phrase addiction doesn't discriminate, and the cliche is certainly technically true. No one's immune from developing an addiction, but it's also true that drug overdose rates are much higher among some population subgroups and in some places than others in the US. And that's really what my research explores, and in particular, this article. So these figures show trends in fatal drug overdose rates by age group and by race ethnicity. These are the trends for males from 1999 through 2020. And in the younger age groups, which are the top figures, you can see that whites and American Indians had the highest rates over the whole period. And that rates among those two groups began increasing much earlier than rates among Blacks or Hispanics. In the middle age group, Black males had higher rates in the 2000s, but then rates for whites and American Indians surpassed those for Blacks in the early to mid 2010s. And by 2017, rates were higher among Blacks again. Then in the two older age groups, you can see that rates have been highest among Black males for the whole period, which is not something that we've tended to hear in the narrative about the overdose crisis. And in addition to that, we see these especially large increases from the mid 2010s on, when fentanyl really started to enter the scene. This slide shows the same charts for females, and we see similar patterns in the younger age groups with consistently higher rates among American Indian and white women, followed by Black women. In the 45 to 54-year-old age group, which is an age group that's gotten a lot of attention, American Indian women continue to have higher rates than the other groups. And then in the older age groups, rates for Black women have caught up to and even surpassed rates for white women. So again, in those older age groups, there's this interesting phenomenon going on where Black males and females have higher rates than the other demographic groups. And that's been especially the case in more recent years. So if we consider the last 2 decades overall, from 1999 through 2020, the highest rates have been among American Indians, males and females, ages 25 to 64, Black males 35 to 64, Black females 35 to 44, and white males and females 25 to 54. As we saw in those previous slides, Black males in that 45 to 64-year-old age group have experienced especially rapid increases in recent years. So that's kind of the who has been most affected and how it varies a bit by age and race and timing. But the other part of this story is about where fatal overdose rates have been the highest. And if you take a look at these maps, which show overdose rates overall, these aren't just opioid overdoses, they're drug overdoses overall for reasons that I can talk about later after others have had a chance to talk. But these are rates at the county level from 2000 to 2010. And rates have been consistently high in Appalachia and in the industrial Midwest. But in recent years, the rates have also increased throughout New England and Mid-Atlantic and the Gulf Coast and the desert Southwest. Throughout the entire period, overdoses have remained comparatively low in places like the Mississippi Delta, most of Texas, most of the Great Plains. What most of those counties that are shaded red have in common is that they're economically disadvantaged in general, and they generally have poor health and high premature mortality. So when I think about this, I think about how in general, these are places where a large share of the population is suffering in some way or another. So I'll pause there and turn it over for the other discussion and can share information about different types of drug involvement later if folks are interested.
Shannon, quick follow-up question. Can you say a little bit about your theory about why what do middle-aged white men and older Black men have in common that would make them more susceptible to the epidemic?
That's a great question. And one of the things that scholars who work on this have speculated is that the timing of economic declines was different for different demographic groups. So if we think about the unraveling of economic opportunities, the decline in manufacturing jobs, for example, for primarily whites without a four-year college degree, which started to happen more in the 90s and 2000s with effects manifesting in the late 2000s, 2010s, That's similar in many ways to the unraveling of economic opportunity that took place in inner cities in the couple of decades prior. So we think about the age group differences that we're seeing here. The cohort of Black males that was experiencing the unraveling of economic opportunity in, say, the 70s and 80s, perhaps began drug use at that time. And then once fentanyl hits the scene and is contaminating the supply of drugs that they have been used to using, the risk of overdose increases. Meanwhile, white males weren't exposed to opioids and other drugs that increase opioid risk until a bit later, a couple of decades later, and the demand for those drugs wasn't quite as high among those groups until that vulnerability really set in the 1990s and 2000s.
The theory is that the risk factor isn't just poverty or low economic opportunity, it's a change from a worsening of opportunity.
Yeah, I think my position on this for the past several years is it's not just about economic disadvantage per se. It's about the way life is now compared to what one's expectations were for life, for what life would be, and compared to what people saw happening in the previous generation. So it's a combination of, in some places, long-term economic disadvantage, intergenerational economic disadvantage. In other places, the vulnerability was created as a result of the breakdown in opportunities for upward mobility.
Gosh, I would welcome an opportunity to continue that conversation. That we have lots more. Let's move on to Jessica Pack. Thank you, Shannon.
Are you seeing the correct slide? Yep. Okay. Okay, so thanks so much for having me today. My name is Jessica Peck, and this is joint work with Christine Durant, Lonnie Berger, and Deb Ehrenthal. And the question that we're trying to answer is, what is the effect of opioid use during pregnancy on infant health and well-being at birth? So we know that pregnancy and the first year of life are particularly important for child development. There's a lot of research that's showing that impacts and investments during this period have lifelong impacts on child's well-being well into adulthood. And one of the questions that started to emerge with the opioid epidemic is, what is the effect of exposure to opioids in utero? So there's some research that, excuse me, tries to answer this question by basically comparing the infants of mothers who were known to use opioids during pregnancy to infants of mothers who did not use opioids during pregnancy. And the estimates that came from these studies basically showed that opioids were very detrimental to infant health, to neonatal abstinence syndrome, to a range of other measures of neurocognitive well-being. However, one of the problems is that a lot of these studies were unable to net out the effects of other factors that are associated with these outcomes. So like maternal health, pollution, things exposed, exposures during pregnancy, income, nutrition, all of these factors. So in this paper, we used a very unique linked administrative data set to basically make comparisons within mothers across siblings. Theoretically, this should reduce the effect of all of these other things because they're shared, right, across mothers or within mothers. And that the only difference then between the siblings is how much opioid exposure they had in utero, and whether there was any opioid exposure in utero. So as I said, we use this linked administrative data set here in Wisconsin that allows us to capture longitudinal data of mothers and infants during pregnancy and then after birth. And we use this to create basically a calendar of opioid exposure so that we could see different types of opioids. For example, prescribed opioids, analgesic opioids. We could also see treatment opioids that are used for treatment of opioid use disorder. And then we also used diagnosis dates to infer when we think illicit opioid use was happening. So for example, if we observed a long period in pregnancy where there wasn't any prescription opioid, but then there was an opioid use disorder diagnosis, for example. And what we found first is that nearly 1 in 6 infants with Medicaid-funded births are exposed to opioids at all during pregnancy. So obviously this is a select sample, but this is a sample that's very relevant to the opioid epidemic. But when we look at the sample of mothers in our primary analytic data set who have at least one child, or have at least 2 children that were born on Medicaid, we find that over half of those infants are exposed to opioids in utero. We also find, and we talk about this in the paper, that non-MAT prescription opioids are the most common types of opioids, and that illicit are most commonly used in the first trimester. Everything else kind of increases over time. So, there we go. So first, we conduct cross-mother estimates. So we compare the infants of mothers who used opioids to those who did not. And that's the blue bars that you see here. And we're looking at a range of infant health outcomes. So for example, NAS is neonatal abstinence syndrome, low birth weight if a child is small at birth, preterm if they're born early, small for gestational age, low APGAR score, which is just a summary measure of health, whether or not they were subject to a CPS report within 7 days, and whether or not the child was admitted to the NICU. And we find that when compared to the cross-mother estimates, where you can see there's a large effect on NAS diagnosis and CPS reports, and somewhat smaller, but there's still an effect on these other health outcomes. When we make these cross-sibling estimates that reasonably control or attempt to control for these differences, the effects are a lot smaller, but they don't disappear entirely, meaning that all of these other factors likely contribute to these negative health outcomes, but that opioids still persist. We also find that the type and the timing of opioid exposure is consequential. So we find that generally MAT and illicit use impacts infant health much more than prescription opioids, and that these effects generally match the graph that I showed you before. But the big takeaway here is that non-MAT opioids or prescription opioids have a much smaller effect in general on infant health and on these behavioral consequences. Okay.
Jessica, say a little bit about what the potential policy implications are of what you've found.
Sure. So there's a couple of things kind of building on what Shannon said. There's obviously a lot of contextual factors and other policies and other practices that have to be taken into mind when thinking about how infants are directly or indirectly affected in terms of the opioid epidemic. But we'd also say that it's important that mothers are transitioned to treatment as early on in pregnancy as possible. However, we know that there are many barriers to treatment. So, for example, the location of treatment centers and the ability of mothers to get prenatal care, all the various barriers to prenatal care also exist in getting access to treatment. And then one of the problems that we have here in Wisconsin is substance use during pregnancy is criminalized. So we know that more than likely, and also do the work of my collaborator, Christine Durant, deters access to treatment as well. So we would say thinking about those barriers and the context in which they exist is very important when thinking about prescribing policies, especially those that address the holistic needs that families have.
Thank you.
Thanks.
Lindsay.
Great. Okay, so I'm Lindsay Bollinger. I am at the School of Public Policy at Georgia Tech, and this paper is collaborative work with a former student of mine who is now in medical school, Vivian Wang, and Kenny Fetter, who is at Johns Hopkins University. So Shannon showed us the trends in mortality, particularly among adolescents and adults. We're going to look at younger children here, and basically the trends are all the same for children as well. So for example, if we look at neonatal abstinence syndrome rates, these have been increasing over the past 2 decades. If we look at the number of children living with an adult with opioid use disorder, this has been increasing over the past 2 decades. If we look at children living with an adult who's using heroin, this has also been increasing, though not as rapidly, perhaps, as the previous figure would show. And then if we look at children who are living with a parent, or children who have experienced a parental death due to substance use, this is also increasing over the past several decades. And then finally, if we look at entry into the foster care system due to parental drug use, this has been increasing, particularly in the last decade here at the tail end of this figure. So We all know that children have been largely affected. They are carrying a large burden here of the opioid crisis, largely through indirect measures, right, in their living arrangements and these sort of positions. And so I just want to take a moment here and highlight how common now it is for children to be in foster care placement. So for example, at any point in their childhood, 6% of all children in the US are placed in the foster care system. And this is especially prominent for children of color. So 15% of Native American children will spend some time in the foster care system, and almost 12% of Black children will also experience a stay in the foster care system. Now, this isn't necessarily due to parental substance use, but it's a fairly common phenomenon. So we know that children have been carrying this burden of the opioid crisis. Less is known about what we should do about it and what are some of the policy solutions that are working. A few examples here are prescription drug monitoring programs, Good Samaritan laws, pain clinic regulations, naloxone access laws. And these basically have been getting inconsistent effects on child well-being measures. And in our paper, what we aim to do is examine whether medication-assisted treatment can alleviate some of the burden of the opioid crisis on children. And so specifically, we're asking, do medication-assisted opioid treatment programs affect child maltreatment and foster care? To examine this question, we are looking at an interesting administrative decision that occurred in the state of Indiana, which lifted a moratorium, a longstanding moratorium, on the opening of medication-assisted treatment programs. And so in 2013, those counties with the blue shades are the counties that had an opioid treatment program. By 2019, there were 5 counties that opened. One of them was within the same county as a previous location. So the 4 red county shades here, these are the new locations for the opioid treatment programs by 2019. So what we do in this paper is we're especially interested in maltreatment and foster care entry. And basically, we don't really see that these opioid treatment programs have any effect, any significant or consistent effect on CPS reports for child maltreatment. We might see a suggestive reduction here in reports for physical abuse, but in general, we don't see anything significant. However, when we look at foster care placements, we see a reduction in out-of-home placements by about 22%. And if there's anything that you take away from my 5 minutes here, it's this figure that I want you to remember. So what we're seeing here in this figure is that basically in the time leading up to the opening of these new opioid treatment programs, we don't see any significant difference between counties that didn't get an opioid treatment program and the 4 new counties that did. But as soon as those opioid treatment programs come into play, within the next year, we see a reduction here of about 22%. Okay, so in conclusion, our paper, we also look at a few other outcomes in the paper, but I didn't share those results with you, but we see increases in methadone dispensing, which is what we expect to see, and reductions in opioid overdoses in those counties as well. No significant effect on maltreatment reports. However, we do see this reduction in foster care placements by 22%. We think this is important because we think that opioid treatment programs may affect the most severe or the most complicated cases of maltreatment. And we estimate a direct savings of about almost 21 million to the state of Indiana in regard to these stays in the foster care system. And there are many of you on this webinar that are in social services agencies. And so we think this is particularly relevant within the context of the Family First Prevention Services Act, which is really focused on foster care and in particular, the role of substance use, for example. So thank you very much.
Would you say something about why you think the treatment had an effect on placements, but not reports of abuse? Sure.
So cases, child maltreatment reports that have any sort of substance use, they are typically much more complex and much more severe cases of child maltreatment. And so what we think is happening here is that on average, these OTPs, these opioid treatment programs, aren't necessarily affecting sort of the average child maltreatment report. However, they are affecting what you might think of as sort of the most severe types of cases that are going to lead to foster care entry or removal from the home at all.
There were some counties in Indiana that already had similar programs.
That's right. They had been around for many, many years.
Did those counties have similar results, lower rates of out-of-home placement as the 4 additional counties, or was there something about
Yep,
introducing?
so we actually dropped those counties from this particular analysis in part because the creation of these treatment programs was part of a bundle of a variety of policies. And for example, this decision, this policy increased funding to existing opioid treatment programs. And so we did not want to capture that effect. And what we really wanted to capture was if you didn't have easy access to an opioid treatment program before, and now you do, how does that change the landscape for the kids in the community?
But you can't directly compare them to the counties that already had similar programs.
So we could, I mean, technically we could. The problem there is that I think it's actually asking a very different question, right? It's asking about no longer access to an opioid treatment program, particularly with, geographic access. In order to engage in opioid treatment program, this is a regular appearance at an opioid treatment program location. And so if we're comparing these counties that previously had an opioid treatment program, then the question is less about geographic access and more about enhanced resources to existing programs.
It's a really interesting idea for a study. I really enjoyed reading it.
Thank you.
Jessica, tell us about education.
I will do my very best. Thank you. The research I'll be talking about links the opioid crisis to student learning rates, which I conducted with my co-authors listed here. And I always like to include this photo. This is really where my interest in the crisis began. I lived in this trailer park in northern Maine in middle school and got some early exposure to the ripple effects of the crisis. So my co-authors and I, what we really wanted to know was whether the epidemic, with its many ramifications on people and their families, we wanted to know if it was creeping into classrooms. And to do this, we combined 2 sets of data. One data set provided every county's average annual learning rate using test scores from every public school student in the country. This learning rate tells us the annual improvement in standardized test scores for a cohort of students as they move from 3rd to 8th grade. So you can think of this as the average amount of information a student learns in class every year. The other data set provides the annual per person rate of prescription opioid pills distributed by pharmacies in a county. So this measure reflects the number of prescription opioids physically distributed within a community. So we took all of these county learning rates and all of these county pill rates, and we linked them together to see if there were any notable patterns. It's important to note that this is aggregate data, so this is not a study that specifically looks at children using opioids, nor at children whose family members are using opioids. Instead, we're looking at all students. So as it turns out, children in communities that are overrun with opioids are learning less material each year than their peers in less affected communities. So in this figure, the blue dot represents students in less affected counties. These children are learning faster. The orange dot represents students in highly impacted counties. These students are falling behind bit by bit, year by year. This is true for all students, no matter their race or ethnicity or their family's income background. The orange dot students are always learning less than the blue dot students. This is true even when we account for differences in community context and differences in local school systems. We do find evidence that characteristics of school districts partially explain the relationship we see. This suggests that opioids are affecting student learning in part by affecting dynamics inside the school themselves. For example, it may be the case that in hard-hit communities, school funding has been diverted away from supplemental learning and enrichment activities in order to meet students' basic needs. We also know that school budgets are already stretched thin by increasing special education costs associated with prenatal opioid exposure. Before I talk about implications, I want to caution that this is not a causal analysis. We're describing associations, but what does make this analysis powerful is that it includes nearly every county in the country and every U.S. public school student within those counties. We're describing associations, but we're doing so very comprehensively and with great precision. This map gives you a sense of that, and the darker shaded areas represent the most distressed counties. So what do? First, there are several school-based needs that can be addressed through policy and everyday practice. This includes funding for increased staff support like counselors and social workers. Children are arriving at school hungry, tired, stressed, and it's imperative that their needs are met. Teachers have also voiced the need to access trauma-informed trainings that cover the effects of addiction on families and classroom strategies for engaging with affected children. Meeting these needs requires funding, and litigation brought against companies by school districts is an important tool for addressing the epidemic's effect on U.S. public schools. So we're hoping that some of this litigation that's relying on research linking in utero opioid exposure could perhaps rely on future causal research that will also enable them to seek restitution for students exposed to community opioid presence throughout childhood.
Jessica, you wrote a lot in your paper about the possible pathways, the ways in which opioid use could affect student learning. Some of them were in the classroom, some of them were out of the classroom. You talked about hunger, you talked about disruptive students, you talked about pressures on the school budget, and a long list of things. But then overall, you found that the reduction in learning was modest, 4%. What should we think about that? Does that suggest that the schools are actually doing a pretty good job of containing the damage, or is that not the way you would look at it?
Yeah, I think a important distinction to note is the difference between achievement levels. So like what an average test score looks like in one of these communities versus how much, like the increment to those achievement levels from year to year. So if you're looking at achievement levels, the results are more dramatic because there's a lot of things that go into like a child's ability to do well on a test on a given day. But when you're aggregating how much each student in a county is like incrementally adding to that score year after year, I think you see a lot more sort of diffusion.
But is that a potentially is a potential interpretation of that the schools are acting as a inoculating force to some extent, compensating force?
I think it probably depends on the school. So I think schools that are like well-resourced and have the ability to meet the needs of these students that are coming in are able to help push those students along academically while also meeting those needs. But the number that I give, that's a sort of 4% of the average amount of material you learn every year, is a national average. So if you zero in on communities that are more distressed, you probably are seeing bigger dips in those learning rates.
Thank you. I thought it was a lot of interesting stuff to think about. We have a question that actually I was from the audience that I had in mind as well. I don't know who would be best positioned to answer it, but the question is, how does opioid addiction affect housing stability? I didn't see anyone's research address that directly, but does anyone have a thought?
My research doesn't address that, but I have some thoughts that I can share. It's pretty well established in the literature that people who have substance use disorders of any kind are more likely to have unstable housing. And this is a kind of a secular effect. So, having an addiction can lead to job loss, income loss, trouble with relationships, marital dissolution, which can lead to housing insecurity. But at the same time, being housing insecure can lead to the kind of stress and despair that might make somebody want to take a chemical vacation. So those things interact with each other to make it really difficult for people who are housing insecure to recover from that addiction, and for people who have addiction to be able to obtain and maintain stable housing.
So the causation can go in both directions.
That's right.
Jessica Pack, we have a question from Alexander Chung. As a Canadian, you write, all mothers have access to prenatal care since there's a universal healthcare system. In the US, does Medicaid pay and provide for consistent prenatal care? And does quality prenatal care improve opioid outcomes?
Sure. So births are generally fundable by Medicaid at a higher level. However, it depends on the state, right? What the Medicaid eligibility level is, what the threshold is as far as income. But some states have more generous packages of care and are more generous in terms of eligibility than others. As far as funding substance use treatment, I know that it's covered here. I'm not sure about other states, but would imagine either people here can speak to that. But I know that it's covered here.
On international comparisons, we had another question asking if any of you all have a comparative reference for what's different about the opioid epidemic in the US from other countries, either in the extent of it or in the public policy response. Nope. If not, Shannon, let me ask you to go back to your geographic variation. I can't remember another presentation that I've heard where the Mississippi Delta was pointed to as a place immune to the impact of social problems. Say more about why an area of such entrenched hardship would have lower, less problems with the opioid epidemic.
So I wouldn't say they're immune to the challenges of social disadvantage. What I hypothesize is happening is that the manifestations of the disadvantage, in other words, the ways that those communities cope with disadvantage looks different than in perhaps other parts of the country. And there are various reasons for this. One of the early drivers of that was that, opioid prescribing rates were lower among Blacks than among whites. There was discrimination among doctors that led them to treat pain less well among Blacks. And of course, the largest share of Blacks in the US live in the South. That's part of it. But actually, if you look at maps, opioid prescribing rates themselves are pretty high in the South. So it can't just be about prescribing. There has to be something else going on there that is acting as a kind of buffering effect. Some scholars have speculated that in the Mississippi Delta, the role of the church plays a really important role. They're very tight-knit communities. They're strong social organizations that may act as a deterrent or a buffer against substance use. But I would note that for nearly every other cause of death, rates are much higher in the Mississippi Delta and other parts of the South than they are throughout the rest of the country. Rates including things like heart disease and other obesity-related causes. So the manifestations of disadvantage, I think, just look different in places like the Mississippi Delta than they look perhaps in New England or parts of the industrial Midwest.
Anybody else have a thought on those kinds of explanations for geographic variation that come up in your work at all? Lindsay, I wanted to circle back to something from your presentation. You found that the availability of the expanded treatment in the 4 counties reduced the number of kids in foster care, but you noted that it wasn't clear if that was due to fewer entries into the foster care system or speedier exits. Can you tell us a little bit more about what's behind that question and whether you have any intuitions?
Sure. So unfortunately, we are unable to disentangle entries from exits from the system. So what we're measuring here are placements. And indeed, it's true that child welfare cases that involve parental substance use tend to have the longest time to reunification. So the longest time before a child can exit the system and return to their families. And so it may be that substance use treatment is expediting that time for reunification, perhaps in part because substance use treatment, undergoing substance use treatment is a requirement for getting kids back oftentimes. So it could be reducing entries into the foster care system, or it could be getting kids out more quickly.
Do you have any guess?
I do not, just we don't have good data on this, so some of the questions that have been coming up in the chat are about some of these measures. And I would encourage a lot of the folks who are on this webinar who work in social services, researchers would love to have data on things like entry versus exit, or on things like race and ethnicity of a child, or on having, the county or other fine-grained geographic identifier. But oftentimes these data are just not available. And we sort of got fortunate with the case of Indiana in that they do at least post their data on placements and child maltreatment reports, but we don't have age of the child. We don't have race or ethnicity of the child. We don't have if they're entering or exiting. And a lot of times if you see research that has this sort of information, it's either, one state, for example, Wisconsin, where Jessica is, they do have their robust data available at the individual level, but it's limited to, select researchers. And there are, national repositories of data, but they are oftentimes not reporting geographic identifiers for most cases. And in the case of studying opioid crises, this is really important because of the burden that rural areas, in particular, smaller counties in particular, have experienced. And those are usually the ones that are suppressed.
We have a question from the audience about the impact of some of the opioid settlement suits. Did you in your research come across anything promising? Did you get any sense of to what extent or in what ways that money was being put to use, whether it was helping?
I chatted with Keith Humphreys about this before our webinar, and he said we don't really know what impact the funds are having because they're really just hitting communities now. But he did caution the historical experience of the tobacco settlement funds and how the vast majority of those funds have not been spent on the repercussions of what tobacco brought to the United States. So some interesting food for thought as we do see the rollout of these funds, what types of requirements are or are not attached to how those funds are spent.
If you were the fund czar, tell me what you would like to do with some of the money. Any of you?
Well, in my case, just because I'm already off mute, I think what I mentioned at the end of my presentation, there are children in schools who desperately need help getting their basic needs met right now, let alone help thriving in school. So I'm a big proponent of more counselors, more social workers, more people who are making sure that kids in school are able to perform academically at the level that they can, and not because they're being held back by other things happening in their lives.
I would agree that early childhood intervention probably has the most bang for the buck. My inclination about these settlement funds is that most of them are being used to subsidize medical companies and pharmaceutical companies, given that a lot of the funds are being used to increase access to Narcan, medication-assisted treatment, and other types of substance use treatment. So that's, that's trying to tackle a problem after it's already here, rather than trying to prevent the problem to begin with. And that's the status quo for population health in this country. It's what we have historically done. It hasn't ever worked. It's made the problem worse. I would like to see most of those funds be used to try to prevent substance use initiation. Early childhood education is a prime outlet for that. But in addition, I think that those funds need to be attached to some structural interventions that might take decades for us to see the effects manifest. This means long-term investments in the types of building the types of economic opportunity and family stability and social institutions that have eroded in many of the regions of the country that have experienced the worst problems. And that need for long-term investment means that policymakers and the public have to get comfortable with the idea that the observable effects of these investments won't be instant. We didn't get into this mess overnight, and we're not going to get out of it overnight by throwing a couple $1 million around to increase access to treatment in Narcan.
Our time is up. If we were together non-virtually, I think I would stand with the audience and give you all a round of applause. Thank you very much. Thank you, Tom, for doing this. There was one statistic that was included in the preparatory materials that didn't get mentioned somehow, I think, today. And that was that I think you said, Tom, 1 million people have died from the opioid epidemic. I suppose I should have known that, or should have had that more frontally in mind, but it really struck me when I read it. And it's a sobering thought to close on, but with that, I will hand the important conversation back to you. Thank you.
Thanks. Thanks very much to the panelists and to you, Jason, for doing this. Circling back just for one hot second to the question of housing stability. There are 2 other papers in this volume that deal with this in very specific kinds of ways. One by Monica Cadillo and colleagues that shows that higher local overdose death rates are associated with fewer children living in stable 2 married parent households, and increase the likelihood that children are going to be in unstable family structures. And then another one by Andrew Sullivan and colleagues that shows that the presence of medication-assisted treatment programs in specific locations did not really have a discernible relationship to homelessness at the community level. And they argue that the presence of these programs are not in themselves kind of an effective approach to treating homelessness, that more comprehensive approaches are necessary. So with that, I just wanted to close that loop because I knew that there was more content in the volume. So it's even more of a provocation for you all to go and take a look at the volume online. I want to thank particularly our colleagues at the Institute for Research on Poverty at the University of Wisconsin. Were it not for their partnership in this, we wouldn't have nearly the audience that we do or the reach. Their list is terrific. Our list is terrific. And together we do even better. So thanks to colleagues there as well. And again, to our panelists. Be well. And I think we're going to close on that.